that number through time and see if there's an elevation of more than 0.75 in 1 year, then we're going to do a biopsy. So, but we do. I mean, it's not so clear with microwave therapy and cryosurgery and all the different therapies people can use for prostate treatment, but we know that it should go down. And but if it doesn't, then again, you're alerted to possible cancer.
And I just want to emphasize for the men, but just early this week, I had a fellow who was a new patient to me, and he'd been to other physicians, and he'd had PSAs. They've always been normal, but he hadn't really yet had digital rectals because some physicians no longer don't want to do them. And when I did the digital rectal, the right lobe of his prostate had multiple nodules in it, and I just went back to see what the PSA was. It's still in a normal range, but he's still going to go to Dr. Thompson. I told him that, regardless, because you cannot. No test is perfect, and if you do it right, you'll get the best yields for patients.
If there are gentlemen who refuse rectals, which a lot do, we have to trust the PSA, but I try to convince them the rectal is also still a very important test. There are instances where we don't do a rectal for different therapies that a patient's had, but it is very valuable and should be done on a yearly basis.
I always tell them they're really lucky because they got a doctor with a small finger. It seems to work.
I was very unlucky in training because I did my residency with a female who had very long fingernails, so all the guys would line up at my door, not her door. All right, so a little bit about prostate. I'm sorry. No question.
One question. You hear a lot on the radio and TV about these body scans.
Mm-hmm.
And there's pros and cons. Do you have any comments?
Well, the body scans are usually not. I'll defer that to Dr. Ross.
Why don't we let Dr. Thompson finish, and I'll answer that question.
So in terms of cancer, when we diagnose cancer, the idea is we have to find out whether the cancer has gotten out of the prostate or not. The prostate is surrounded by a capsule, and one of the first tests we do is we do something called an MRI of the prostate, and that will show us whether there's extracapsular spread of disease. If there is not extracapsular spread of disease, then this patient is a very good candidate to be cured by therapy. In terms of the therapies available, if a gentleman is young, if he's healthy, surgery is proven to be the best option to cure their cancer. And at Mercy, I'm the chief of robotic surgery. We have a robot there where we're removing prostates, saving the nerves for erections and incontinence, and we're curing a lot of people. There are other treatments available. We have radiation therapy for people a little older, a little sicker, who can't have a big surgery. We have seed placement to cure the cancer. There are various treatments, external beam radiation, et cetera, based on the therapy. But the most important thing is getting that patient in, getting them evaluated, diagnosing their cancer, and getting them therapy. And again, we're curing a lot of people. What about if we catch it a little bit too late? A gentleman they can't get their husband to come in. They can't, they won't have the testing. They won't have the rectal exam, the PSA, et cetera. And their PSA is elevated. We have other therapies, hormonal therapies, some more testing, chemo, et cetera, to treat those patients with advanced disease. And those patients are staying alive longer than they used to. The fight there is to try to save them in terms of, it's a sad topic, but everybody dies of something at some point. A lot of these patients, we're keeping them alive longer to where they're not going to die of their prostate cancer. So there are so many therapies out there for prostate cancer. So again, it's 1 in 34 as opposed to 1 in 20 and then 1 in 10 years ago. So it's very treatable, very treatable. Okay? Any questions at this point? And then we'll go on to some of the other issues.
Okay. Yeah, contact information?
What's that?
Contact information.
Out there, I have some cards outside. Now, in terms of some of the preventative therapies, people are always asking, as we've already answered some of the questions about preventative therapies, and we talked about this company, and we have done, this company has done testing on patients following FDA guidelines, and we have several entities that we're going to talk about. They're not in the right order. My secretary apparently was in the middle of lunch, she was typing this, but Prostate 2.2 is a formulation, and the gentleman in the back talked about zinc. And what has happened is they did a study of cadavers, people who've died of prostate cancer, and they I think it was about 10,000 patients. They looked at their blood levels, and there were several substances that were very low in all these patients across the board. Soy products, selenium, vitamin E, vitamin D, and again, there's a pamphlet in the back. So this company came out along with, based on all the research from all the top urologists in the country, and they formulated this for prostate, prostate health in terms of these are the chemicals that are what they think are needed to prevent prostate cancer, and there's a pamphlet out there for that. One gentleman talked about the saw palmetto. That's more for BPH, frequency of urination, et cetera, et cetera. So there's a saw palmetto pamphlet out there. Some of going a little bit away from prostate health, Theracran. Some of the females in the room are having UTIs. These are some of the medications and supplements that are available to some of our patients who are having these issues. So pamphlets in the back if you're interested from that standpoint. Any questions?
You have enough pamphlets in the back?
I brought as many as I had. I have a big box full of pamphlets for everybody. If they want to look at preventative measures to try to prevent prostate cancer, bladder cancer, different things on your list here today.
Preventive diet also?
There's a book on preventative diet too. Absolutely. Absolutely.
Is there a history, like if your husband's father had
Yes.
prostate, that?
We tell you, yes, family history is one of the biggest entities, a genetic predisposition. So if there's a family history, everybody starting at the age of 35 gets a PSA and a rectal every year. So
Okay.
please pass that on. One of the most important, we know that more than anything. We know that genetic predisposition is important. Black males need to be evaluated. Several other, very job-related issues, but that's not as important as those two things.
No blood type relation?
No information, blood type relation at this point. Not related to your blood type at this point. Although there's lots of research going on, so who knows, that may prove to be significant down the line.
Is there a relationship to testosterone level?
The only relationship to testosterone is when we're trying to treat prostate cancer. Prostate cancer feeds off of testosterone. So a gentleman who has prostate cancer, a lot of the medical therapies that we do, we try to reduce the testosterone level so that the prostate cancer cannot, it's like a car running on gasoline. Prostate cancer runs on testosterone. Take away the testosterone, the prostate cancer cannot spread, cannot multiply, etc. So that's one of the therapies we were talking about with patients who have advanced cancer, and this is one of the reasons a lot of prostate cancer living, they're not dying with their prostate cancer, is we have hormonal therapies that can drop the testosterone level down so that prostate cancer goes into submission. Remission.
Can increasing the testosterone level promote the...
Yes. Yes, we take patients off all of their testosterone products if they have prostate cancer. Absolutely.
So it is not advisable to take testosterone supplements.
If you're a urologist or your primary care feel as though you might be you have a chance of developing prostate cancer, we should take away testosterone supplements. Absolutely. Thank you very much. Appreciate it.
Thank you.
I'm gonna, does anyone, after we talk about the prostate, does anyone have to go to the bathroom? Because we have bathrooms if you want, you know where they are. But if not,